sir. Okay, this is on aortic valve disease. Go ahead with the first slide. The aortic valve aortic valve, of course, is a lot simpler than the mitral valve. It consists of three cusps normally. These three are not quite, I thought for years they were the same size, but in actuality they're not quite the same size. There are three commissures, of course, and the thing that allows this valve to open is that the distance between any two commissures is greater than a straight line. And the fact that it allows it to come open and shut. This slide is an attempt to show the structure of the aortic valve, and that is the number of aortic valve cusps in patients with aortic stenosis. And this is isolated aortic stenosis, that is normal mitral function. And it shows that in the age group under 15, that the most common valve structure is a single cusp. In the age group 15 to 65, the most common structure is a bicuspid valve, that is two cusps. And in the age group over 65, most commonly a three-cuspid valve. So the principle, the younger the patient, the fewer the number of cusps. The older the patient, the greater the chance three cusps. This slide examines the structure of operatively excised aortic valves in nearly 400 patients aged 17 to 74 with isolated aortic stenosis. What I mean by that is normal mitral valve function. Anyone, again, with stenosis may have regurgitation. They usually do, except for the older age group. And this shows about the same as necropsy figures. About 7% of these patients had a unicuspid aortic valve, 52% a bicuspid valve, 26% a three-cuspid valve, and about 15% it was not possible to tell from examination of the specimen. Fortunately, most of the surgeons in the Washington area excise these valves intact. When I have my valve excised, hopefully never, I want it excised intact if at all possible. Now, what does a unicuspid valve look like? In the aortic position, this is the only one that's been seen. There's a single commissure, goes all the way around, comes back, no other lateral attachments to the wall of the aorta. This is an example of that. That's a single commissure there. The cusp goes around, comes back, no other lateral attachments. This is a relatively uncommon configuration in a stenotic valve. This particular patient was 62. There's a right coronary artery and the left over here. That's congenital heart disease, in other words. The bicuspid valve is common, relatively common. If mitral valve prolapse affects 5% of persons, the bicuspid valve affects at least 1%. So this is the second most common congenital heart disease. Mitral valve prolapse 1, ventricular septal defect 3. Despite the fact that the bicuspid valve is relatively common, there's relatively little natural history information on this valve. Probably one of us in this room has a bicuspid valve. How many persons born with a bicuspid valve go through lifetime and have no dysfunction is unclear. Sir William Osler in 1885 was the one who pointed out the extreme propensity of this valve to be the site of infective endocarditis. It was not pointed out until the late 1950s that the bicuspid condition was a relatively common underlying malformation in patients with aortic stenosis. Indeed, prior to that time, which is only 25 or so years ago now, it was not appreciated that the bicuspid valve could be stenotic ever. And it was not until 1978 that it was pointed out that the bicuspid valve can cause severe, wide-open aortic regurgitation, severe enough to warrant valve replacement without superimposed infective endocarditis. There are basically two structures of the aortic valve. One is when the cusps are located anteriorly and posteriorly, and in this setting, both coronaries arise in front and from the same cusp. And then there's a right and left configuration. Here, one coronary arises from behind each sinus. Now, this is a reason, I think, why the echocardiographic features of the bicuspid valve are not always uniform. This is a bicuspid valve, a true commissure here, another one here, and false commissure, so-called here, a raphe, in a physician who is 55 years old, classic bicuspid valve. This heart belonged to a nurse who was 46 years of age, totally asymptomatic, low and in an operatively excised aortic valve compared to the peak systolic pressure gradient across the valve. This is based on not a large number of patients, but we x-rayed the operatively excised valves, graded the calcium 0 to 4 plus, and what this does show is that the greater the calcium in the valve, the higher the gradient. We've got some larger numbers now, and it's virtually a straight line. If one starts in patients over 15, of course, in the younger age group, there's no calcium. Nobody's ever born with a calcium in a valve. That's always acquired. Aortic regurgitation is a very interesting type of cardiac abnormality, of course. The mechanism of regurgitation can be due to either abnormality of the cusps, scarring or whatever, tearing, perforation, or to disease of the wall of aorta. And involvement of the cusps is either not present at all, and these are the two classic conditions causing that. And then there's one condition which affects both the wall of aorta and the aortic valve cusp, and this is ankylosing spondylitis. Now this slide summarizes causes, etiology of operatively excised aortic valves in patients with pure aortic regurgitation and normal mitral function. Now, definitions in valve disease are absolutely, just like anything else, are absolutely crucial. If one included, for example, patients with dysfunction of both mitral and aortic valves, the etiology would be very different. But to my utter surprise, 46% of these patients were classified, at least by me, rheumatic. Of course, that has to do with definitions. But at the time of aortic valve replacements, the mitral function in all of those patients was normal. Many of the patients came back years later, however, with evidence of mitral stenosis, mitral regurgitation, and indeed quite a few later underwent mitral valve replacement. Infective endocarditis was quite high. 24 here, this is bicuspid valve without infection. So that was the third most frequent in this group. Now this is a group I think that has not received much attention, systemic hypertension as a cause of aortic regurgitation. And I'm talking about aortic regurgitation, not a little whiff of it, but aortic regurgitation severe enough to cause class 3 and 4 symptoms and to warrant aortic valve replacement. These were valves that were anatomically completely normal, and the aorta was maybe a little dilated, but not much. In other words, the mechanism of the regurgitation in this group is unknown to me. But this is a group that may come in with a blood pressure preoperatively of 160 over, let's say, 70 or 60 or 50. And then after operation, when they're seen at 6 months post-operatively, the blood pressure systolic may be the same, 160, but now the diastolic is 110. It's a very interesting group, but it's a difficult one to know why a regurgitation occurs. The Marfan syndrome, or form fruus varieties of that, syphilis with ventricular septal defect, and so on. Now this is an example of rheumatic aortic regurgitation. Here, aortic valve cusp, diffusely fibrotic, and considerable retraction of those cusps. Now, although this patient presented with pure aortic regurgitation, and if it's rheumatic, the mitral valve is not normal anatomically, and here it is, anterior mitral leaflet is diffusely thickened, but the mitral valve functioned normally. Infective endocarditis, the most common mechanism of regurgitation, is perforation or tears or rips. That's an unusual mechanism of mitral regurgitation from infection. Unfortunately, infective endocarditis is still a major problem. Of 100 people who develop infective endocarditis, about a third die despite antibiotic therapy. About a third are left with such severe valvular dysfunction, namely regurgitation, that a cardiac operation has to be performed in subsequent years, and only a third are really cured of the infection by antibiotic therapy. The greatest advance since antibiotics for infective endocarditis is the availability of cardiac surgery, which has changed the course of infective endocarditis a great deal, of course. Now this is Marfan syndrome. Marfan syndrome is, or form fruus varieties of that, is characterized by dilatation of the sinus portion of aorta as well as the proximal tubular portion of aorta. The dilatation, that's the nominate origin of the nominate artery there. The dilatation stops before origin of a nominate artery. Now, to appreciate how large that is, this is a right coronary artery here, and that's the left main there. Obviously, enormously dilated aorta. That needs focusing, I believe. This is the same case, and the reason the picture was taken was because of that tear right there. A sudden bleeding into the pericardial space because of a tear in aorta. This is the classic Marfan aorta, dilatation in the sinuses and in the proximal tubular portion. If one looks at these aortas, on the interior, these tears are very common. They may be longitudinal, transverse, or whatever. Now, these tears have often been called dissection, but these are not dissections. In 18 patients with the Marfan syndrome that I've seen at autopsy, only 3 had dissection. So in my experience, a dissection is relatively uncommon in the Marfan syndrome. Dissection and a tear are not always the same thing. Now, this is the normal media of aorta, and the normal media is characterized, has 3 things in it. It has elastic fibers which stain black, it has smooth muscle cells in it, and fibrous tissue. Now this is an aorta in a patient with Marfan's who had a very aneurysm in ascending aorta. And here we see virtually no elastic fibers. Here are a few residual right there. The red are the smooth muscle cells, and the greenish material here is some acid mucopolysaccharide material, and the yellow is fibrous tissue. But the major feature of the Marfan aorta is the massive degeneration of elastic fibers. Now that's been called cystic medial necrosis, a very poor term, but I'm afraid I don't know a better one. This is syphilis. Here's a huge dilatation of the aorta in syphilis, but in syphilis the root of the aorta, that is the portion of aorta behind the sinuses, is not dilated, where it is in the Marfan syndrome. So here we have a heart. It's a little heart, normal weight, no dilatation of left ventricle, and yet huge dilatation of the aorta. In syphilis, the process is like a dumbbell. The aorta is dilated except for where the valve is, and the aorta is often much bigger than the left ventricle. This is the histology section in a patient with syphilis. This is the aortic valve cusp right here. This is the wall of aorta behind the sinuses. This is an origin of a coronary artery, and here the aorta is perfectly normal, which it is usually in syphilis, whereas at the site of the coronary artery and above that, the wall gets very thick, extremely thick, and that's what characterizes syphilis. It's a paradox, really. The aorta is thicker than normal, but it's weaker than normal, and the reason it's weak is the elastic fibers have been interrupted by these large medial scars. This is an example of syphilis in which aortic regurgitation was a problem. Of patients with cardiovascular syphilis, only about 1 in 10 have a significant aortic regurgitation. So regurgitation is a minority, not a majority. The regurgitation is primarily a central leak due to the fact that the distance between commissures becomes more or less a straight line. And this is ankylosing spondylitis. Histologically, ankylosing spondylitis looks like syphilis, but this process not only involves the aorta, but the process extends into the aortic valve cusp, primarily the basal portions of them, and it also extends below the aortic valve. So it causes considerable thickening of the proximal portion of the anterior mitral leaflet. It also thickens the membranaceous septum here and may extend into the conduction tissue. So left bundle branch block, complete heart block is very common in ankylosing spondylitis, whereas it never occurs in syphilis. This is ankylosing spondylitis, a drawing simply to show the process involves aorta and primarily the sinus portion of aorta, the base of the aortic valve cusp, and the base of the anterior mitral leaflet. This is an example of systemic hypertension as a cause of regurgitation. Obviously, the systolic pressure is going to be high. Preoperatively, the diastolic pressure was not as low as usual, but this pressure stayed up postoperatively rather than coming down. Now this slide shows some anatomic characteristics of the heart and aorta in patients with various types of valvular heart diseases. The major point here is that today rheumatic heart disease is a relatively uncommon cause of lesions on the left side of the heart, that is the non-stenotic lesions. 25, 30 years ago, almost all heart disease was called either rheumatic heart disease or syphilis. But I would point out that all of these various diseases have their anatomic characteristics, and these can cleanly, in my judgment, be diagnosed by examination of valves and certainly the heart. Thank you very much. Lights on.